So thanks everybody for attending today. Um, this is our, I don't know what number of work in progress we're up to now, but this is I'm Steve Rich, and I'm going to be joined by John Briggs today. And I think this is, at least on my part, is very much a work in progress. Back in August, when we were looking to schedule the WIPs for the fall, I thought, I'd like to talk about communities of practice because I've been thinking about them for a while, and I thought it would compel me to sort of get my thinking in line, and it has done that to an extent. But I'm by no means an expert in this, so I'll apologize for that. I'm not a social scientist, but the way I tend to think about these things is more like from an ecological perspective. I'd have to admit that I'm not an ecologist either, and that if I went to the beach and there was another ecologist there, they could probably kick sand in my face, and there's not much I could do about it. But I do think sort of ecologically about how these interactions take place. Um, and I remember the first time I heard the word community of practice was on a project that Dr. Guangxu and I were brought into. It was the four-poster study on Cape Cod and the islands. EPA was working with Barnstable County to to evaluate use of four posters to reduce ticks on the Cape and Islands. And we came into it late because it was really about tick control. And then later on, they decided that they wanted to do some pathogen testing, and that's how we were brought in. And I remember the EPA guys mentioning, that they had a community of practice approach, and sort of looked at me and said, "You know what that means, right?" And I nodded, and I didn't necessarily know exactly what community of practice was then. I have a little better understanding of it now, but I thought we could talk about it and how it's applicable to the work we're doing in the center. It is one of the components of the center. And I thought it would be worth having a conversation. And I'm thinking of this very informally. I'm happy to be interrupted if anybody wants to chime in or ask questions about what I'm going to talk about. So the first thing that I would point out is that um, I think most of us are aware that ticks are not mosquitoes, but I think that's an important thing to remember, that the way that tick control works may not work the same way that mosquito control works. Also, probably not news to anybody, but it is worth just remembering the basic biological differences between ticks and mosquitoes, everything from the fact that they don't fly to they have a very different reproductive strategy. They don't have dependency on water, for example. So their distributions are very much different. So there's a lot of different reasons in a biological sense that ticks are not mosquitoes. The other thing is to just think about the historical perspective of this. So very often people will wonder why there isn't tick control when there is mosquito control, and that really, to a large extent, is a matter of history. When the mosquito control districts in the Northeast or the United States were being developed, it was really only a couple of decades after pathogens had been associated with vector-borne diseases, and most of the human pathogens at that time were transmitted by mosquitoes, whereas ticks were largely more of an agricultural problem, or not necessarily recognized in North America as a public health threat. And obviously that changed with the changing landscapes in the 70s and the outbreaks of Lyme. But that's one of the reasons that we haven't had a historical institutionalized vector control for ticks the way that there are for mosquitoes. I also like to remember that all those pathogens that sort of drove the early notions of mosquito control, and now I'm thinking about in Central America and elsewhere, were about anthroponic diseases that were transmitted from people by mosquitoes to other people, even yellow fever in North America and malaria in North America as well. Whereas most of the pathogens that we're dealing with, the ticks, are enzootic, so fundamental biological difference. And then the last piece is just like the abundance and frequency of the pathogens. So on average, sort of surveillance has a very different perspective when we think about surveillance and ticks, because we talk about a pathogen like Lyme disease this time of year with adult ticks, about 50% of them are infected with Borrelia, which is a very different scenario than mosquitoes, where the pathogens are rare, and the efforts to go and reduce the mosquitoes where the pathogens pop up is more practical than trying to imagine doing that for a similar approach for ticks. And I mention all this because at least one of the first clubs that people would take out of the bag is to figure if in going to saying how can we develop a tick control program would be to say how can we use existing vector control programs towards the end of reducing the abundance of ticks. And this is an excellent paper. I'd hoped that Jim Burtis and Becky and Lars could be on the call. I don't think anyone's here from CDC, but they're not. So this is an excellent paper that they put out last year, just talking about a survey that they had conducted of these VCPs to ask how willing they may be or what capacity they had to take on ticks as an objective. And here you see the results of that. So in about 11% of those VCPs actively suppress tick populations, despite uh, I can't even read myself, despite 90% conducting mosquito control. And most tick control focused on education and surveillance. So again, fundamental difference in the way that those approaches are taken. Sorry. And then identifying the different barriers in order. Number one, funding. I mean, that's the thing that I think would have anyone concerned is taking an unfunded mandate, taking on some whole new set of responsibilities without having a concomitant increase in the funding. Personnel shortages, lack of standardized protocols, and need for training were other things that were recognized in that survey. Continuing on that, so I just focused on a couple of focus areas and gaps that they identified in that paper, and one was lack of standardized surveillance protocols, and evidence-based suppression techniques and communication strategies for public engagement. And the reason I kind of focus on those is that actually our project Itch, in many ways, is sort of speaking to each of those, standardizing surveillance protocols, coming up with evidence-based approaches, and I think most importantly, developing communication strategies for those individuals that are participating in itch, these the individual homeowners. And so this is ostensibly, without necessarily putting into the design initially, we were creating or have created a community of practice around Project Itch. And so it's worth thinking about how communities of practice get set up, how we can. I don't think you build them. I think what you best you can do is you can cultivate the relationships within the community of practice to make them stronger. But by and large, I think by definition, they're not built structures. They're structures that arise from a need and then can be utilized for different functionalities. So I mentioned this to John, who's seated in our laboratory space now here in Fernald Hall, that I was going to be doing this, and he had he had an interest in expressing in talking a little bit more about mosquito control and the nuances of mosquito control, and asked if he could do a whip. And I thought it would be good to have it in this context of talking about community practices. And so that's why John's here, and John's going to speak about that in a moment. What I want to do is just before we go into that, just give sort of some general overview of community of practice if people aren't familiar with this, and sort of set some a framework for having that conversation. So this is a figure that came from our original protocol, our original proposal, and I draw your attention to the lower right-hand corner where we had discussed creating a ParkNet, and ParkNet was our partners in applied research and control of New England ticks. What we quickly realized in practice when we started to go about developing the ParkNet and accumulating these affiliates was that the affiliates had a number of different needs, and they were just fundamentally different. So, for example, the way we worked with an affiliate that was a PCO would be very different than the way we worked with an affiliate, for example, that was a Board of Health. And so we recognized that it was necessary to probably not have a single community of practice, but understand that there might be different communities of practice that would be nurtured in different ways. Just a couple of slides. There is a I guess it's social science, a perspective on how these community of practices are set up and how they evolved. It's this person, Eddie N. Wenger, who's written a couple of books, or at least one book that's occurred in a couple or appeared in a couple of editions. I have read that book. It's there's a lot there, uh, a lot that's kind of hard for me to get my head around, but it does seem that there are certain features that we can sort of utilize to understand how to make those communities of practice. There's just a couple of those that are characteristics of successful communities of practice. One is that participation is voluntary. So I think one fundamental difference between the way we think about communities of practice and the way we think about agencies that are involved with control or other efforts is that these generally don't have a top-down organization. They don't have a structure that's hierarchical. Very often there's peer-to-peer relationships that are going on here. There's an importance of knowledge sharing, collaborative learning. It's self-governed in the sense that the participants usually have their own hierarchical structure, and so there's always sort of uh, a need for recognizing that those structures don't have a strict organizational foundation. I also like the notion that they have organic evolution because one of the things that we see is that the communities of practice can evolve over time. So considering these steps in that evolution can help to understand how to cultivate that community of practice in a way that you can advance it through those different stages. All of that to me was is somewhat complicated in that there's a lot for me to get my head around. So what I always try to do is simplify things. And I started to think about communities of practice in terms of just three interacting components. One is there are deciders. So they're the individuals that are making decisions on particular actions. And then there are providers that are providing the resources that are going to be utilized by the deciders. And then there are guiders that are giving information on best practices and both to the providers and the deciders. And I think a lot of what we can think about is just those arrows that connect those different participants in the process. And it's kind of a useful framework that describes lots of different communities of practice. And if you think about it as, again, not a top-down structure, but rather one that can be iteratively adapted to particular needs, then you can start to imagine how those practices could be optimized over time by increasing communication between the different levels and having appropriate feedbacks between the different components. So to just give examples of where this has worked successfully. So farm to school nutrition programs, there are deciders, which are usually school board members and district superintendents. There are providers like cafeteria staff and teachers and local farmers. And then there are guiders, which are the nutritionists and the agricultural extension and public health educators, all of whom are contributing to making sure that that farm nutrition program is set up in a way that it's functional, that everyone is incentivized, that everyone is rewarded for their participation in it. And that's one of the reasons that these programs become successful. Another example, which is a little bit more of an internal example that might happen within, for example, an individual hospital, is the control of or reduction of hospital-acquired infections. You can imagine that the deciders are hospital administrators or department heads that are making decisions on practices that are going to be utilized. There are the nurses and physicians and environmental services that are the providers of those services. And then the guiders, which are the epidemiologists and infection control specialists that are looking in on those systems and advising on best practices. So we can take that sort of model and expand it to think about different decider, provider, guider groups that we have. For example, we could think about a recreational community practice model where there's hikers that are making a decision. They have to make decisions on what they're going to do to keep ticks safe. There are providers like outdoor supply stores that are going to be giving the products that they'll use to treat their clothing or treat their skin. And then there's guiders like land managers and DCR and departments of conservation resources and those types of things that provide that information. And where NUVEC can come in, or NUVEC may be at some time a guider, sometimes it may be just sort of facilitating the communication between those groups. That was my image for what communities of practice might look like. And I mentioned this to John. And well, here's another example where just the last example, which is itch, where the deciders are the homeowners, the providers of the PCOs. I already alluded to this one, and then the guiders might be extension or agents or boards of public health that are telling the deciders what the best practices are. So when I mentioned this to John, he had already was primed to come and talk about mosquito control, and the he tried to make it fit sort of this model, and I think it might have been a kind of a tight fit, but I appreciated that they made the effort, and so I thought it was a good way to talk about in a practical sense how this ethereal example could be used in a very practical sense. So with that, I'll hand it over to John and let him switch and talk about mosquito control. Let me stop my share. And I'll introduce John Briggs. He's the superintendent of the Pioneer Valley Mosquito Control.
Thanks, Steve. So Steve just walked us through what a community of practice looks like in theory, and I'll hopefully show you what that looks like in practice from the mosquito control side. Mosquito control and surveillance in Massachusetts isn't a single program or agency. It's rather a complex and coordinated system that involves both the state and local officials. This presentation looks at how this system functions as a community of practice, where state agencies, local boards of health, and with mosquito control districts each play a role in reducing risk and protecting public health. So I'll start with an overview of the MCDs in Massachusetts. There are 11 MCDs where each has a designated service area. As you can see by looking at the map below here on the left, for instance, Pioneer Valley, our service area includes 25 communities across Franklin, Hampshire, and Hampden counties. All of the mosquito control districts operate under Chapter 252, which was enacted in 1918, and it was actually for nuisance and not response to disease. And that makes sense around our area. At the time, Triple E was not on anyone's radar until really 1938, when the first human case was confirmed in Massachusetts. However, it was first documented in 1831 when over 70 horses had died, and they suspected it was from Triple E. So there was a gap in Triple E activity. People forget very easily, and I imagine so back then even more. Uh, but it likely has to do with habitat degradation. Right around the turn of the century, folks started to use cedar as building materials. And this was over-harvested from cedar swamps, which happens to be the primary habitat for Chelicedum melanura, which is the primary vector for Triple E. So Chapter 252 has been amended several times, but overall, a good portion of the legislation is still from 1918. So the State Reclamation and Mosquito Control Board sits within the framework of Chapter 252. It's composed of 3 members from Department of Agriculture, DEP, and DCR. The SRMCB is a state-level authority that creates and approves mosquito control districts, control projects and districts. They also oversee districts, how districts operate, and review budgets and assessments. So at the district level, it's a little different. We have a board of commissioners. Ours is a board of 5. They oversee policy and direction related to budgets and program scope. They establish the overall framework of the district, and once that's in place, it is my job or the superintendent's responsibility to carry it out. So membership and funding structure, this is where it gets a bit complicated and can really affect things. Municipalities have the option to join the district that covers their area. There are two types of funding methods that districts use to charge towns: unrestricted general government aid determined by the DOR. We also call this the cherry sheet, which is the state's official notice of estimating local aid and assessments for each municipality. The second funding mechanism consists of voluntary contributions, which come directly from a town's budget. Now, it's either one or the other. When districts are established under Chapter 252, they must first determine how member towns will appropriate funding. And this, as far as I know it, cannot be changed once the district is certified and formed. So the cherry sheets districts will set their fees based on equalized valuations, or EQV, and total land area. Depending on EQV and land area, towns could be paying anywhere between $20,000 and $200,000 annually. That's a significant amount of money. Because the funds are from state aid and not coming directly out of the town's budget, it is surprisingly less scrutinized and a bit easier to create that line item. The downside to using the cherry sheet is that a lot of the smaller towns or towns with low growth don't receive enough funding or state aid to appropriate funds for MCD services. That's where voluntary contribution districts come in, and they charge a flat buy-in rate across the board. This is meant to cover core operational costs. Member communities have the option to access a menu of services where they can pick and choose which ones they want. The funds are typically sourced from local Board of Health budgets or free cash. And because the money is appropriated directly from town budgets, it is highly scrutinized, unfortunately. Even in affluent communities, $100 extra going towards mosquito control is sometimes questioned and needs to be justified. We are a voluntary contributions district, and some public health directors are constantly in a position where they are fighting to stay in the district. The upside to this funding method, however, is that it is fair and equitable for all communities, regardless of wealth. Obviously, it presents its own set of challenges regarding mitigation interventions in towns that have limited funding. So what is the role of MCDs and what do we do? I want to begin by emphasizing that our primary and shared goal is to reduce the risk of mosquitoes transmitting Eastern equine encephalitis and West Nile virus to humans across the Commonwealth. We do this through larval and adult surveillance, which is the backbone of any integrated mosquito management program. We aim to monitor medically important mosquito species and assess their abundance and arbovirus activity to inform controlled decisions. There are 11 genera and around 52 different species of mosquitoes in Massachusetts. We are mainly interested in bridge vectors such as Aedes vexans, Coquillettidia perturbans, Culex salinarius, Ocleritatis canadensis, and Ocleritatis japonicus. And of course, there's our primary vectors, Culex pipiens restuans, which will amplify West Nile virus among the bird population, their preferred host being the American robin. And of course, Culecia melanor, which amplifies Tripoli among the bird population. The species that I just mentioned don't all necessarily share the same habitat. Culex pipiens and Ocleritatis japonicus, for example, do have overlapping habitats, as both of these species prefer artificial containers. Coquillettidia perturbans, on the other hand, are specialists and can be found submerged in swamps with emergent vegetation. So habitat analysis is pretty important and typically begins with GIS software and shape files that map hydrology and classify wetland types such as deciduous and coniferous swamps, shrub swamps, bogs, etc. Ground truthing and sampling these areas help us to locate and prioritize breeding areas. So source reduction and habitat management focus on reducing mosquito breeding in areas where water tends to collect. That includes identifying and treating catch basins, ditches, and other holding areas that retain water long enough for larvae to develop. Some districts also have a tire collection program. We don't. But where in those districts that are participating in that or offer that, participating municipalities can turn in off the rim tires or discarded tires for proper disposal. By reducing these sources, we limit the need for chemical control and target mosquitoes before they emerge. Community outreach is a huge part of what we do. We work with residents and local boards of health to share information on how to reduce mosquito habitats, prevent bites, and stay informed about local risk levels. The goal is to keep communities engaged and proactive because really public awareness is one of the most effective tools in reducing mosquito-borne disease. Larval and adult control are carried out only when surveillance and risk data show it's necessary. That's in our district. Every treatment is evidence-based. We respond to what the data tell us. Control efforts are focused on where mosquitoes are active or where disease risk is elevated. So state partners, the Massachusetts Department of Public Health is one of our key state partners. They conduct molecular testing on the mosquito samples that we submit. They develop statewide risk maps and assessments and coordinate surveillance efforts across districts. Their data and guidance give us authoritative backing for local decisions, and they play a leading role in public outreach and messaging about mosquito-borne disease prevention. The Massachusetts Department of Agricultural Resources houses a state reclamation and mosquito control board. It gets confusing. MDAR provides administrative oversight to the districts, fiscal management, and legal guidance to all of us. They also help coordinate communication, collaboration among districts, ensuring that programs operate consistently or are in compliance with state laws and environmental regulations. And Mass Wildlife, we also work with them through their Natural Heritage and Endangered Species Program. They play an important regulatory role in mosquito control and determine which control products can or cannot be used within designated priority habitat areas to protect listed species. I should also mention that we do work on the federal level with NOAA and endangered species. We have the short-nosed and Atlantic sturgeon that are present in the Connecticut River and some of its major tributaries. Because of this, we have to be cognizant of when and where we're applying larvicides to avoid any indirect trophic impacts. So assessing risk. DPH assesses arbovirus risk by looking at surveillance data across mosquitoes, animals, and people. Risk isn't assigned town by town, but across what they call focal areas, clusters of communities that share similar habitats and patterns of virus activity. Several factors are taken into account: the abundance of vector species, where and when virus is isolated in history of activity or human and animal cases, and that type of habitat and population density in the area. Seasonal weather and timing also play a big role, especially when warmer conditions support vector mosquito growth and extend their activity. Risk levels can rise quickly when virus is detected in mammal-biting mosquitoes. When those detections occur earlier in the season, this happened with us in Belchertown. We had one one positive of coquelicity of perturbans for triple E. Luckily, we didn't find any subsequent positives. So the map to the right is provided to the public by DPH. We are constantly referencing this map. It's a great tool, great outreach tool, great way to get the public more engaged and more informed. The colors range from low in beige to critical and dark red. The same is done for Triple E, but I could only fit one map on this already very busy slide. Sorry about that. You can see that higher risk areas cluster around Middlesex, Worcester, and Norfolk counties. It's not surprising. These are urban areas, environments, which create ideal breeding conditions for Culex pipiens. Again, the primary vector for West Nile virus. DPH updates these maps regularly throughout the season as new data come in. These maps guide communication and control decisions, helping MCDs and boards of health know when to ramp up surveillance, larval treatments, and outreach. So examples of response actions starting on the left. When DPH confirms positive mosquito pools for Triple E or West Nile virus and the risk is considered low to moderate, they notify both the local board of health and the mosquito control district. From there, the district reviews the trap data to confirm the species involved and the surrounding habitat. For instance, if it's Culex pipiens, we'll often inspect and treat larval sources such as catch basins or other localized breeding areas. Routine adulticiding continues as well in districts that offer it as a routine service, targeting vector species where activity supports it. So control work generally focused within about a 1 mile radius around the positive trap site and includes sensitive locations like schools, senior housing, and recreation areas. We also increase surveillance in that focal area, adding supplemental traps or testing more frequently and coordinate outreach with local boards of health. The public messaging at this stage centers on personal protection and source reduction, limiting standing water and preventing bites. So on the right, going over that example, when Triple E activity reaches a critical risk level, typically when a human case or multiple animal cases are confirmed, the Department of Public Health formally designates those areas as critical. In these zones, both local and state officials have the authority to preempt individual no spray requests in order to protect public health. Now, in Massachusetts, private residents can request no sprays officially requested, sign up online through MDAR's website, and we are limited to applying certain amount of larvicides and with adulticide, there is about a 300-foot buffer around their property. So in coordination with DPH and MDAR, the State Reclamation and Mosquito Control Board may authorize and oversee emergency adulticiding. These efforts can include large-scale aerial or ground-based ULV applications to quickly reduce vector populations. At the same time, mosquito control districts continue their own targeted adulticiding within affected communities, focusing on local hotspots where vector species are confirmed. Surveillance and testing are then ramped up to assess the impact of treatments, while DPH and local boards of health continue public messaging and risk communication. So arbovirus mitigation as a community practice, or in the community practice method, it is not clean. There's a lot here. But when it comes to mitigating risk, several key groups play decision-making roles. The Department of Public Health assesses arbovirus activity and issues formal recommendations when control actions are warranted, especially when we get to those higher risk levels. The State Reclamation and Mosquito Control Board can authorize and fund emergency control operations in areas where risk is elevated. Local boards of health may approve treatments and implement measures such as reducing outdoor activities during high-risk periods. And lastly, us, the mosquito control districts, determine when and where to carry out control measures within their member communities, which is guided by surveillance data and state recommendations. The guiders focus on communication, education, and outreach. At the national level, the CDC provides arbovirus information, prevention strategies, and overall public health guidance. The Massachusetts Department of Public Health translates that into a state level action by publishing risk maps, issuing health alerts, and sharing prevention recommendations. Mosquito control districts support these efforts locally by hosting outreach events. We do a few listening sessions throughout the season, providing educational materials and advising boards of health on consistent public messaging. Local boards of health then share these advisories and educate residents directly on reducing breeding sites and protecting them from mosquito bites. Providers are responsible for carrying out mosquito control operations. Mosquito control districts handle most of the on-the-ground work, conducting larval and adult control, managing breeding habitats, and conducting surveillance to guide those efforts. When large-scale or emergency operations are needed, state-approved vendors step in to assist under the authorization of the State Reclamation and Mosquito Control Board. Together, these partners keep control measures coordinated, targeted, and responsive to changing risk levels. So sustaining community of practice. It's rather complicated. This is a rather complicated example of community of practice, but it is sustained through shared goals and strong coordination. Our collective mission is to protect public health, reduce the risk of mosquito-borne disease, and support informed, coordinated decisions across all levels of government. Cross-agency collaboration is obviously key. We need to continue to strengthen communication among DPH, the SRMCD, MDAR, mosquito control districts, and local boards of health, because by working together, we can close surveillance gaps, keep outreach and control strategies consistent, and continually evaluate outcomes and emerging needs. The goal is to keep improving, advancing, and sharing best management practices that help every partner respond effectively to changing conditions and protect communities across the state. So by no means is this perfect. There's a lot of moving parts at the state and local levels. However, the strength of mosquito control in Massachusetts is that no one does it alone. It's a coordinated practice and effort that keeps adapting. But with that, I'll go ahead and send it back over to Steve.
And I'll open it up to the audience for questions. Something in the chat. Kyle Rosenthal has a question for you in the chat, John.
The question is, has there been for lack of a better word, freeloader concern from some towns where those voluntarily engaged in the MCD program cause benefits for adjacent towns in the same risk area, but not otherwise participating in the program financially, or a desire to make the program administered at a higher level, county or state, besides just large scale or emergency events. So with us, with voluntary appropriations, everyone pays the same rate, the same flat rate. And if there's any control, unfortunately for towns that can't afford it, they're not going to pay for control services or mitigation services. Even when there is an increased risk level. And now if you're looking at it too from a state level with the SRMCB, just this past season we had a human case in Worcester County. It was in a town that was not a member within a mosquito control district, and that town and surrounding towns received mosquito control services. It was a truck mounted ULV that was funded by the state. So there is a concern about towns. I suppose my concern is towns looking at that and saying, well, we really don't have to do anything, because if it gets really bad, then the state's going to come in and foot the bill. Um, but my argument to that is that's not sound public health strategy, and that we want to do more preventative. We want to do more outreach with their constituents and whatnot. So did that answer your question, Kyle? Excellent. You're muted, Steve.
Thank you. Matt Kaline sent a question, says, we have a tick education community of practice in New Hampshire called Tick Free New Hampshire, with a website and other projects funded by New Hampshire DHS, CDC, and a private individual. What kind of long-term funding mechanism might work best in Massachusetts or other New England states? Matt, I think the simple answer is first to try to convince, for example, employers of green industry individuals that are that have exposures to ticks and tick-borne diseases, that it's a worthwhile effort for them to invest in these kinds of training programs. Um, I gave a talk last week to 100 foresters at their annual meeting in Westminster, Massachusetts, and there was also some, oh, you wouldn't call them trade unions. I don't know what you call it, but that organization, it's called the Massachusetts Forestry Alliance. Um, they would be, I think, good partners for communication, sending out these communications and training for their constituents. Um, we're frequently called upon. Next spring, I'm giving talks for master gardeners, and they usually will have a budget to, at least pay an honorarium to have people go and speak. So I think there's resources out there. Um, of course, CDC and DPH are good sources, but I think the extent to which you can put it in um, a payer model, that the more sustainable those things will be. I don't know if you're able to hear us, Matt, and if you had a follow-up question. I know you're sending those through Jane. Or are there other questions in the group? I always wait for that long, awkward pause in case there's someone that's just shy. Nolan's not shy. I know he would say something if he had a question. Okay, not seeing anything in the chat and not seeing any hands raised. Um, I'll thank John for his presentation today. It was fantastic. And give you all your 15 minutes back. Thanks for attending. We'll see you all again in 2 weeks, I believe. Is that right, Jane? Are you listening? Thanks, everybody.